So we're continuing the conversations on the breast cancer conversation, and we couldn't do that without Dr. Lyronne Olivier giving us some insight, as your expertise lies where surgery in the breast is concerned. But what is your proper title and area of study?
So I'm a breast surgical oncologist. What that means really, I deal with the surgical removal of the tumor.
Right.
But I think what is important, sometimes I might be the first contact for a patient with breast cancer. So I always make the statement that anxiety is rendered by a sort of a lack of knowledge of the actual breast cancer process and what to expect. So I sort of encompass everything, even though it may not be my forte in terms of the surgery alone.
Right.
So they're actually what you have medical oncology, which deals with the actual treatment, and then you have surgical oncology, which deals with removal of a tumor, and then you have things like radiation oncology, which deals with treatment after the breast cancer surgeries, what have you.
Right. Now, I mean, education is what we're all about. So let's start with giving a little bit of distinction between the different types of breast cancer, because we have the conversation every October, breast cancer, but there are differences, aren't there?
Yeah, I mean, mainly the differences are, if we look at the structure of the breast is made up of two main structures, we can say. There's the element that produces the milk, and then there's the element that transport that milk to the nipple. So the breast cancer can arise at any of that sites. So the two main breast cancers you have is ductal carcinoma, which deals with the ducts, which deals with the pipes, and then you have the lobular cancer, which deals with the lobules that produce the milk. The ductal cancer is the most common, which is about 80%, and lobular is about 20%. But I think we still need to highlight one other element. It's sort of a misnomer, something called ductal carcinoma in situ. So it's actually not a cancer, but the name suggests carcinoma. It's a pre-malignant condition. We know that if we leave it, it may turn into cancer. So it's treated as aggressive as breast cancer. So the two main headings for this sort of discussion really is ductal carcinoma, lobular cancer, and then because of the increased use of mammography, we see more what the pre-malignant condition called ductal carcinoma in situ.
So we were talking amongst ourselves as Caribbean women, understanding that we are very prone to certain types of risks, and because it's in our family, we have a little bit more information. But what should we be paying attention to in terms of risk factors when it comes to breast cancer?
So when you talk about any pathology, and breast cancer is what we focus on today, you talk about factors that you can modify and factors that you cannot modify. So you have modifiable factors and non-modifiable factors. So we can talk about the non-modifiable factors first. And the first thing is just being a woman. We know that every woman has the 1 in 8 women will get breast cancer in their lifetime. So that works out about 12% lifetime risk. So just being a woman alone, you have a risk of breast cancer. Yes. The other risk factor that you may have is one of age. So we know the older you get, your risk for breast cancer increase. So for example, a woman in her 30s is 1 in 227, which works out to roughly about 0.04%. And if you jump up to 60, 70, it's 1 in 28, 1 in 24. That works up to about 3 to 4% lifetime risk. And that's for that 10-year period. Yeah? So we know that just age alone too is another factor. So those are things you can't change. Right. We know breast cancer is significantly related to hormonal issues, things like your estrogen levels and your progesterone levels. And once we start talking about that, we start talking about menarche, and that's a scientific term for basically the onset of your period, onset of your menses. We know that if you have your menses at an earlier age, generally consensus is around 12. It varies now significantly, actually. There are patients now who have their period, young ladies have their periods around 9 and 10. And if you look at the older generation, we're somewhere around 15, 16. So the earlier you start doing your menarche, the earlier your estrogen exposure begins. So it means your risk slightly increases as well. And if we go to the other spectrum, when your periods stop, when you go into menopause, then definitely that will influence your exposure to estrogen. So if your menopause is at a later age, means your exposure to estrogen is significantly higher. And if it is that you have your menopause at an earlier age, then your estrogen exposure is less, so your risk of breast cancer is also reduced as well. So those are factors we can't change.
Right.
Yeah?
What about the ones that we can?
So the ones we can't change is interesting. So we have alcohol, which, every time I give this talk, there's certain patients but people in the crowd that will actually smile.
Yeah, because culturally, Carnival is alcohol season.
I think our whole culture in the Caribbean is about alcohol.
Right, because Christmas we drink, Carnival we drink, happy,
is there a period
sad?
that we don't drink alcohol?
That's the question.
Well, we shouldn't be, it's really directly linked to breast cancer. We know that there's a direct relationship between breast cancer and alcohol. So when you talk about So what we talk about 1 unit of a drink. 1 unit of a drink is about 10 grams of alcohol. In America, it's 14 grams of alcohol. And just to give us estimate about the value of the size of that, that's like 1 carb. Yeah.
Really? And
it's
we
like
will sit and have several at a bar.
And it's like 1 glass of wine.
Ooh, okay.
And it's probably like a thimble of spirit. And that significantly increased your risk of breast cancer by 7%.
And we haven't even started to talk about the way we put alcohol in food, because I mean, fruitcake does contain alcohol.
Do you know that Angostura bitters have significant alcohol in it?
Right. So that cultural and behavioral things is what we're talking about when we talk about ones you can change.
Yeah.
What else do we have?
Things like exercise. We know that exercise, so lack of exercise, we know that exercise actually reduces your risk of breast cancer by 20 to 30%. That is directly related to obesity. We know obesity increases your risk of breast cancer because when you are postmenopausal and you actually have your ovaries are non-functional, your source of your estrogen is actually from your adipose tissue or your fatty tissue. So the more obese you are, the more glandular and fatty tissue you have, the more estrogen your body produces, and that increases your risk of breast cancer. So maintaining a healthy body weight is also significantly important. Then we talk about diet. You know, we always say that diet, you want to eat a healthy diet. You know, a healthy diet is linked, again, some literature will say 30 to 40% risk reduction in breast cancer. So those are some of the modifiable factors that we can control. But then main one, again, when we talk about breast cancer, it's a genetic relationship. I think the general population thinks that, so I'll have a lot of patients that will come to me, Doc, I don't have anybody in the family that have breast cancer. How did I get this thing? Actually, only 10% of breast cancers are related to a genetic mutation. 90% is sporadic. There are many statements I like to make, but on social media I probably shouldn't make it because I'll be held accountable.
You will.
It has to be related to things that we eat on a regular basis. So it has to be environmental factors. And
I mean, imagine there's research to show those sorts of details. So what we really need to consider is that you can't just say because it's not in my family, it's not going to come.
90% is sporadic. 90% we just really don't know. So that's where awareness comes about. That's where this comes about. This is where we are aware of one's breast. So if there's an issue, we can sort it out as soon as possible.
Right. And I think that's important to hold on to, that getting the information, treating breast cancer is very, very possible and very, very necessary, but you can't do that if you don't know. So let's make sure that people know about some of the treatment options that are available. There are many misconceptions there too.
I think if I might just throw you off a bit, I know we may have, I would probably want to talk a bit about screening before though.
Right, tell us the process.
How do we identify breast cancer? So we could have clinical presentations. So we could have a lump, we could have nipple retraction, we could have redness of the breast, we could have skin tearing, skin is pulling in a bit in the breast, we could have a lump in the armpit, we could have a nipple discharge. All these things are general presentation for breast cancer. But we know what we want to do is to pick up the breast cancer when it's not symptomatic, when there's no clinical focus of it. And that's what the principle of screening is. It's picking up a pathology before it becomes clinically relevant. So you're picking up a disease process before you even see any signs or symptoms of it. And that's where screening is, and that's why it's important for us to do screening. And the recommendations, when I came back from Toronto, it was 50. And there's always a big controversy what age you should do, 45, 50, 55. The standard now internationally, everywhere in the world, is 40. So women should start their screening at age 40. If we have highlight points for this meeting, I think that's one of the key points. Breast awareness and breast screening at age 40. Screening, the only recommended tool for screening is mammograms. In the past, a lot of women don't want to do mammogram because it's squeezing their breasts. They don't like the feel of it. The newer machines now are less compressing, so it's less painful. But it's the only tool we can actually pick up cancers very early. They have a lot of new machines now. We have 3D mammogram machines. We have tomosynthesis, which is 3D mammograms, and we get better picture and ability to pick up more cancers. So I just want to highlight that point. I know we won't go into that part.
No, that's definitely necessary because when I think of it, you're right. That would be the prevention better than cure method.
Exactly.
Find it first before you have to do anything treatment-wise.
You see, survival is based on the stage. And what stages? Stages, we base the stage of breast cancer on the size of the breast cancer, if lymph nodes are involved, if there's any spread anywhere. So we have stage 1, stage 2, stage 3. Stage 1, the cancer is confined to the breast. Stage 2, there's some involvement of some lymph nodes in the armpit. Stage 3, it's big, it's more than 5 centimeters, skin is involved, lymph nodes are swollen in the armpit, sometimes lymph nodes in the neck. It's locally advanced breast cancers. And then stage 4 is where the cancer has spread to the bones, the liver, the lungs, or even the brain. Survival for stage 1 is 97%. If we get breast cancer, this is where we want to be. We want cure. We want to be able to have a survival of the high 95s, high 97. Stage 2 is like about 91, 92%. Stage 3 is about 79%, and stage 4 is about 20 to 30%. So that's where we want to be. We want to be in that stage 1, that stage 2. That's where we can get cure, and that's where you have a better survival, and that's where screening is, and that's where awareness is. You know, I can do all the fancy stuff that we're going to talk about in a bit, but the main thing really is awareness and doing this on a regular basis. Because if you can identify the breast cancer early, then the greatest chance for cure. Yeah.
I'm actually really surprised to hear that the age in terms of internationally is still pretty high, because we've seen younger persons who have breast cancer. You know,
so when you set a principle of screening, you're going to have outliers. Yeah? You're going to have somebody who presents in 25, you're going to have, but the general population really is going to be around 40.
Which is why these sorts of forums in these spaces, like the social media, will help to make sure that generations are protected and get the information
and be able to be aware of the breast. So I actually have 21-year-olds, I have 25-year-olds with breast cancer. I know it's crazy. I have 31-year-olds with breast cancer. So really, it's you being aware, and if there's a change, seek consultation, get examined, and principle of triple assessment: history examination, radiological investigation, and tissue diagnosis. Right? That's the principle for any breast lump, any breast issues, and for us to rule out if it's an underlying malignancy, or what we say cancer.
So let's say we do all of that and we do find out it's cancer. Let's talk about treatment now.
So when we talk about treatment, first thing when you're diagnosed with breast cancer is to stage the cancer. And staging can be clinical, where you examine the lump, examine if the lump is involved under the armpit, and we send you for a CT scan generally. And that looks to see if there's any cancer spread anywhere. And the treatment is based on your stage. Yeah? A lot of, you know, breast cancer has evolved, its management has evolved significantly. I really like to talk about personalization of care. I don't like to give this blanket treatment. You have breast cancer, okay, go remove the breast, go have chemotherapy. I think every woman should be treated individually, and that's based on what I would say the receptors or the antennas on the cancer. I know it's a lot for us to get into, it's a lot of medical jargon, but really the cancer, if you picture the cancer having antennas on it, or receptors, it's hormones in the body binds to these receptors and stimulate the growth of the cancer. So we have receptors which we talk about, like estrogen receptors, progesterone receptors. Those are receptors I have in my breast tissue, you have in your breast tissue. And if we know the cancer love estrogen and love progesterone, then we block that. So we give hormone blockers. And then there's another receptor called HER2. And that receptor, it's a growth factor receptor that causes growth of the cancer. If we know you have that in your cancer, we give you a special antibody called targeted therapy, and it kills the cancer. So various patterns of estrogen and progesterone and HER2 give us various patterns of breast cancer. So when you ask me type of breast cancer, that's another in-depth way I could have gone in terms of type of breast cancer. So you could have hormone-positive breast cancers, which are the good cancers I will see on the side, and then you have the triple negative and the HER2 positive, which are the cancers tend to happen in the younger age groups. So patients under the age of 50, they like to come back in 3 years, and we have special treatment. So initially HER2 positive cancers, which are more aggressive cancers, like to come back. But now we have such good treatment that we can actually get these cancers to totally disappear before even reach the point of surgery.
Beautiful.
All right, so, and that's called neoadjuvant therapy. So I'm now delving into the treatment options and how we approach, but I'll give you a cascade how things are run. You know, this is what we talk about every time when I have a patient. So you can have treatment before, which is called neoadjuvant. You could have surgery, and then you could have treatment after, which is adjuvant. And I'm right smack in the middle, which is surgery. So I guide you into the neoadjuvant, which is medical oncologist, and then we have treatment after, which is the either medical oncology, radiation oncology. So really, it's personalization of care, because if you are triple negative or HER2 positive on a certain size, we tend to give those patients treatment before, which is neoadjuvant, and then afterwards they have surgery. So let's talk a bit about the surgery. You know, the big dogma of breast cancer is that if you have breast cancer, you should remove the breast. There's no survival benefit if I remove your breast or if I preserve your breast. So you can remove the breast, or you can remove the lump and preserve the breast. Obviously, it's going to be dependent on the size of the lump. It's going to be dependent on the stage of the breast cancer. But you know, we're not going to get into all that detail, but I'm just saying the general headings. And that's my responsibility, to have that open discussion with you and your family, as well as my entire team. And my team is not just my surgical team, but the medical oncologist, the radiation oncologist, the surgical oncologist, the radiologist, the pathologist, the social worker, and the patient and the family. We all come together in what we call a multidisciplinary meeting.
That's quite the network there. And I don't think that we explore that enough in terms of treatment, because you've specifically talked about this just for the
I've even
surgical
spoken
approach.
to myself as yet.
This is what I'm thinking.
Yeah.
We haven't gone into the pre or post. This is specifically linked to surgery and not even in great detail.
And this is what's personalization. You know, we have all these members of different teams coming together to focus on you. You know, and this is standard throughout, and at least where I work in St. James and in the private sector, and this is the standard that we practice international as well. You know, it's always important that one person should never make a decision in your life. If you find, I am the decision, I'm telling you, this is what you need to do and this is what is best, that should never be. It should always be a team discussing what you want, and it's also your goal as well. So, you know, no longer we practice medicine where a doctor will come and say, this is what you need to have, no discussion, you know. There should be discussions of pros and cons for every option, and you should make a decision with your team.
I'll tell you that I can imagine that being very overwhelming, but at the same time reassuring that you have options, that there is treatment, that there are processes you can exploit, that if one doesn't work, we might have another. So that group effort is kind of reassuring, but it sounds intense.
MDT, multidisciplinary team.
Right. There are more options though, or the other ways that we get treatment, yes?
Yeah. So the main thing is surgery, where we do either remove the breast or we do breast conservation. When we do breast conservation, we talk about oncoplastics. So it's oncology where I remove the tumor, and plastics where I shift the breast tissue around to give you maintained shape and symmetry. Okay. And there are various levels of oncoplastics, which we can talk about at a later time. And that's really is preserving the breast and maintaining the shape. But then you have a mastectomy where you remove the breast tissue. If I do mastectomies, I tend to do immediate reconstruction, meaning that if, for example, you do a mastectomy, you can either save the nipple or remove the nipple. It's called a nipple spare mastectomy or a skin spare mastectomy. And then you do immediate reconstruction, either use an implant, which is called alloplastic, or use your own tissue. Okay. Yeah?
Can you tell me, in terms of options, why then do we see so many patients who actually opt to remove? Is it a cost thing? Is it time and healing? What contributes to that decision?
One, I think it's a bit of ignorance to what the options are. I think it's cultural, where we all believe that if you have breast cancer, that I'm going to live longer if I remove the breast. But there are substantial studies now that show that there's no survival difference if I preserve your breast or remove your breast. Actually, some studies now up to 2024 show a meta-analysis, which we compile different studies of high levels, show that there's a survival benefit. Because patients who get breast preservation get additional treatments. So they get radiation therapy, they get chemotherapy, and those have some factors to increase your survival. So there are, the people rushing to do mastectomies, one, it's probably cultural. Two, is patients not being explained properly. You know, the surgeon or the person doing the operation is not taking the time to explain the options. And then also is availability of skill set and techniques.
Because you are one of few persons who will do the surgical, or specialists rather, in terms of surgical.
So it really depends on your level of expertise in doing oncoplastics and doing reconstruction. You know, but that's something that I have personal goals. Those are things I want to do. What I want to teach surgeons, the surgeons are coming up in techniques and how we can preserve the breast. And not just in Trinidad, but in the Caribbean as well.
Right, even more reason to have hope as to what we can do beyond this particular time. Now, when we talk about the breast cancer awareness, we also talk about lifestyle a lot. So pre-surgery, post-surgery, during surgery, what sorts of lifestyle changes do we need to make?
You know, I mean, these are common questions that patients will ask. Doc, what do I need to do before surgery? Really, if your cancer has an affinity for estrogen, then I would say, avoid things like soya, those things that will promote or stimulate the cancer. But really, it's really having a healthy diet, because your body is going to go through a significant journey where you'll have to heal and recover. And it's not just physically, but it's mentally. So you need to find different parameters of what gets you in a state of mind readiness for a surgery. And that will tend to be, for whatever reason, maybe religious, maybe whatever treatment that you do, exercising, what have you, to get you in that level of mind ready for a surgery, or even family or friends that get you ready. Those things are important. A mental aspect of health is significantly important. We focus on the physical, but mental has a key role as well. And that's just before surgery. And then after surgery is the recovery process. I myself underwent a surgery recently, and it's significantly different side of the table. And it's really lending on family support and eating properly and recovering and being in a good mental state, because the mind has a lot of properties that we don't know that probably may impinge your healing and what have you as well. So
Granted that we talked about that family network and a number of persons coming together to help make that decision, what other resources are available to persons who are dealing with breast cancer, whether it be their family members, themselves, pre and post?
So, it's one aspect, I think, of breast cancer management that we definitely as a country probably need to improve. I think there need to be more. So when we talk about rehabilitation and survivorship, one of my professors, that's one of his goals. He's doing a lot of research and trying to improve that standard in Trinidad. But there are definitely cancer survivors that have come together to form groups.
Right.
So there's EARS, which is, what is the name of that? It's a group that actually a cancer survivor, she came together and she created a cancer foundation.
Okay.
And she actually comes and speak to the patients and discuss with them because she has gone through the process of chemotherapy, radiation therapy, surgery. And it really makes a big difference. It really makes a big difference in helping you find your way through each step of the
you've been through
management.
this, so you could tell me for sure.
So it's that, but really most of the support comes from that multidisciplinary team as well, because you're going to have the surgical aspect, you're going to have the medical oncology, you're going to have the and all those stages we will lend support and give you comms, because we see you every 3 to 6 months.
Right.
After you have your treatment for breast cancer. So at least one of the departments are going to see you. But again, really is a survivorship group. And I always tell patients there are some benefit to this negativity. When you have this diagnosis of breast cancer, you have undergone the treatment, you must lend that experience to someone else. And it's just a network. So these patients actually meet when they have their treatment, and it's like a family when they come together and they have their treatment. All the patients come together and they support each other. So those are the main support groups. But there are other things that we need to focus on, things like, rehabilitation, because sometimes with these surgeries under the armpit, you can get swelling of the arms, so sometimes you need physiotherapists and you need lymphatic massaging and all those things that need to be focused on. And those are some of the things that we need to improve. In the public system, we are offering that now in St. James.
Right.
So you actually have a lymphatic nurse that comes and talks to our patients before and after the surgery. So that's an element that we are trying to improve on.
Well, at least we have the improvement, and it gives a lot of hope and reassurance. So that while, yes, prevention is better than cure, we're doing the screening, we're getting the information, so we don't even have to get to that. But should we, it's good to know that we do have these options available to us. I know this is your month, and I'm glad that you made time to chat to us out, so thank you very much for your time.
It's a pleasure. I'm really grateful that you will give me the opportunity again, because as I said before, it's really about awareness. We can do whatever surgery, whatever treatment, but if we can catch the cancer early, it's the best chance for cure, and that's what we want to achieve.
Beautiful stuff. Next time though, wear pink.
Yeah, definitely.